Good morning, everybody, and welcome in Greece, in Athens. I am very honored to be here in this meeting, as I used to do for the last years. And I'm very happy to try to support the opposite opinion that it is not inflammation, there is something separate underlying as an underlying mechanism in neurodegeneration. Of course, as you may understand, this cannot be supported. And I think that the title of the debate is rather misleading in matters that, okay, inflammation, when we talk about inflammation, and I'm sure that everybody in this, almost the vast majority of our colleagues in this room, whenever they hear about inflammation in multiple sclerosis, what we have in mind is the adaptive immunity, T and B cells, because this is the part of immunity that we are able to control with all DMTs we have in our hands for the last almost 30 years. So there is a part of inflammation that, at least in our everyday clinical practice, we forget or we ignore. And because inflammation is not only the adaptive immunity, is not only T and B cells. So if we, under these circumstances, I can definitely support the position that it is not only inflammation, there are separate mechanisms, but some of these mechanisms are related to the immune system, inflammation. And a previous speaker already mentioned this part of inflammation, and I mean the innate immunity in the central nervous system. So these are my disclosures, and I'm going straight to my presentation, the presentation of my position. Of course, whenever somebody needs to find good reasons that inflammation might not be the predominant factor for the ongoing neurodegeneration in multiple sclerosis, he always may think of the two theories that exist, the inside-out model and the outside-in model. And in this case, what we think is that there is an autoimmune reaction in the periphery, and these autoimmune cells are able to enter the CNS, and since they are activated against myelin, they are able to induce cytodegeneration. On the other hand, there are some other people claiming that the inside-out model cannot be totally rejected for the time being. So there is still a big debate about these two models. And according to this model, there is a primary neurodegeneration, and this may lead to a secondary immune reaction, and thereafter to autoimmunity. In order to judge these two models, probably we may take into consideration the other purely, let's say, neurodegenerative disorders we have in the CNS, such as Alzheimer's disease and Parkinson's disease. However, we still know that even in these disorders, the immune system also may participate. Of course, its presence there is not that massive, is not that impressive as in multiple sclerosis. However, I strongly believe that in immunology, whatever happens is not always a matter of quantity. It may very well be a matter of quality. And particularly in multiple sclerosis, I strongly believe that the problem is in the interrelationship between the immune system and the central nervous system. And we definitely need to have this concept in our mind if we want to proceed further in this and deeper in the pathophysiology of these disorders. So in MS, it is pretty clear that the situation is reversed. Inflammation occurs early and is very prominent in many patients. However, this can simply be not because we have a primarily an immune component, activated immune component, which may then lead to neurodegeneration. It may very well be to other factors, such as age. We have young people in MS, whereas in Alzheimer's disease and in Parkinson's disease, we have more old ages. And we all know that as we, as human beings, become old, our immune system also becomes old and is not that vulnerable to autoimmunity. And another reason might very well be the antigenicity. We may understand that the debris of myelin and oligodendrocyte in MS is a very potent, it's very strong trigger for massive immune reaction, whereas the debris of synaptic and neuronal and neurons, of synapses and neurons that we have in Alzheimer's disease and Parkinson's disease might not be that strong in order to induce or trigger a massive inflammatory reaction. However, we still have both components, and of course, the reason that we promptly believe that inflammation is the core in the underlying pathology, particularly in relation to neurodegeneration, we can definitely start from this point and go forward. Well, it is pretty clear that it's in this rather complex disorder, we have all these elements: demyelination, inflammation, and axonopathy. And of course, it is not only the immunology of MS complex, it is also its pathology, and of course, a very heterogeneous, this is something which results in an heterogeneous clinical profile of the disease. However, what we have in our mind is this rather simplistic, let's say, model in matters of immunopathology for MS. What we believe is that circulating T cells, for unknown reasons, probably there may be EBV, we heard in the previous debate, a number of environmental factors. Of course, it is also pretty clear what we need, that we need a genetic background in, which allows a vulnerability to autoimmunity. But anyway, no matter what the case might be, these T cells become activated against myelin antigens, and this activation enables them to adhere to the endothelium and then cross the blood-brain barrier and enter the CNS. There, in the CNS parenchyma, these T cells are able to become reactivated in the presence of local antigen-presenting cells, and of course, a cascade of events follows with a number of inflammatory components, either cells or chemokines, cytokines, metalloproteinases, reactive oxygen species, and the final outcome, of course, is demyelination and axonal degeneration. And this scenario is nothing but the scenario of the EAE, the experimental autoimmune encephalomyelitis. In this concept, most of the currently available anti-inflammatory drugs we have is based. However, we all know that the whole story is not that simple with MS immunopathology, and I'm going straight to those the clinical profiles of this disease, and let's make some thoughts on the basis of what we see clinically in multiple sclerosis. As we can see here, according to the new categorization by Lublin et al., in the relapsing remitting MS, what we have is we may have activity as identified either subclinically with MRI or clinically, where we have this relapse. And this is fine. Okay, I don't think, is there any pointer? No. It is pretty clear that we have here activity. And what do we mean here by saying activity? I think that the first thing that comes into my mind is that we have an exacerbation, an increased activity of the adaptive immunity, which leads to gadolinium enhancement lesions and then to a clinical relapse. But then things go quite well, and we have a full recovery here. But this is another case where, again, we have activity, inflammatory activity, again, what we promptly have in mind when we say inflammatory activity in multiple sclerosis, and we see another relapse, but here there is a residual neurological deficit. So what happened actually here is, and of course we know that this is disability progression, and this indicates neuronal degeneration. So what is the difference between this point and this point? Could it be that the inflammatory component reacted differently here and here? Or could it be that beyond the adaptive immunity activation, as it is expressed with the relapse, there are some other cofactors, either inflammatory cofactors, or either inflammatory immune, let's say, components, or some other properties of the CNS itself, which led finally to this deterioration of disability. And this is clearly a deterioration, as this one as well. It is not a progression, because when we mean progression, I'm going to show you soon thereafter what we definitely mean. And here is another case where we have a relapse, adaptive immunity activation, but there is no deterioration, meaning that whatever was activated in this case to have a residual deficit was not activated in this case. So I think that it is pretty clear that beyond the so-called inflammatory component we all have in mind when we talk about inflammation in multiple sclerosis is not the only one which may determine whether additional axons will become degenerative in order to have a residual neurological deficit. And just to show you here briefly that, of course, inflammation plays a major role as, let's say, a first event in the ongoing axonal degeneration, simply due to the production of all these inflammatory products, among them reactive oxygen species, oxidative stress, which finally will lead to ionic reconstitution, redistribution along the axon, and finally neuroaxonal damage by apoptosis and necrosis. But is it only due to axonal degeneration, the permanent disability and deterioration or progression we see? Not at all. We also have synaptic pathology. MS is a synaptopathy, and here it is clearly indicated from an MS patient that there are less synaptophysin cocci in the hippocampus of MS compared to normal controls. So it is not only the neurodegeneration, but it is also what accompanies neurodegeneration. And let's go now to the progression, these progressive, let's say, forms of the disease. Again, here we may have activation, as it is indicated, for example, with new T2 lesions or gadolinium enhancement lesions, but still we do not have the clinical expression of the adaptive immunity activation. I mean, we don't have a relapse, we have a progression. So this may further indicate that something additional might happen to the classical concept of the inflammatory component of MS. And of course, as we can also see in EAE, we have neurodegeneration and axonal degeneration with these ovoids and spheroids, and we definitely thought for a long period of time that T cells and macrophages are involved in this neurodegenerative process. I still believe that, as I do here in this paper some years ago, that axonal pathology is still a very complex issue in a complex disease such as multiple sclerosis. So if we need to find or to think about a component which is separate from what we call inflammation, at least, again, I will repeatedly say this, on what we have promptly in our mind as clinicians when we hear about inflammation in multiple sclerosis, because we use drugs, anti-inflammatory drugs, which aim to target adaptive immunity. Again, I think that we should also consider the innate immunity, and particularly microglia and astrocytes. And as you can see here, it has recently been identified this type of A1 astrocytes, which are able to kill neurons, to kill synapses and axons. So in addition to activated microglia, activated microglia impairs glutamate transport in astrocytes and thus promote neuronal and oligodendrocyte excitotoxicity. And I'm not sure that we are able, with the currently available DMTs, that we may interfere with this story. Probably the S1P system is very prominent and very promises a lot, particularly with by the use of siponimod, since we already have some clinical indications about the ongoing neurodegeneration in more progressive forms of the disease. But still, I want to be fair and, of course, go back to the adaptive immunity and just mention again these findings, these tertiary lymph nodes that exist in a compartmentalized inflammatory environment in the CNS. However, I still do not believe that we might be able to do something with these tertiary lymph nodes. Probably we may do something in order to prevent or delay their construction, and I think that anti-B cell treatment, such as alemtuzumab, which is also an anti-T cell treatment, ocrelizumab and ofatumumab, might be useful to this goal. Again, I think that the chronic inflammation, not only the adaptive one, but also the innate component of the CNS, of the immune system in the CNS, is very, very important for these chronic, let's say, changes along the axon in matters of its own metabolism and energy deficiency due to this the oxidative stress. And this may lead further to loss of neuronal fitness, impaired transport along axons, and impaired maintenance of neuroaxonal function. However, and there are still ongoing changes in matters of compensatory redistribution of ions along the demyelinating neurons, which in the presence of excess accumulation of glutamate might finally lead to ionic imbalance and have this degeneration, either the retrograde or the anterograde degeneration. However, we still need to take into consideration that it's not only the inflammation, no matter whether it is the adaptive or the innate immunity, it is also the existence of buffering mechanisms triggered to counterbalance neuroaxonal injury. So, I strongly believe that oxidative stress, secondary to chronic inflammation, but still it's a matter of what we really mean when we say inflammation, is very important for the neurodegenerative progress. Of course, inflammatory, the balance between inflammatory stressors, again, and the intrinsic buffering mechanisms play an important role, and depends partly on age, sex, and genetic factors. There are animal models of MS where we, by using these agents, we were able to see neuroprotective effect, and which was separate from their impact on inflammatory responses. And just to mention that, as we can see here from this study, the axonal injury is not something permanent, as in this case, because you can see here from these video photos, you can see here that this is an axon which is an ongoing, there is an ongoing neurodegeneration here, but still, after a few hours, the axon becomes back to its normal shape. So it means that this may imply that there are also intrinsic mechanisms within the axon which allow him to respond to inflammation. And this is my last slide. I don't think that the consequence of the type of inflammation we as clinicians are familiar with, particularly on the basis of the currently available monitoring tools and DMTs we use, may be the only and clear factor. Innate immunity plays a role, but the currently available DMTs are not able to target this part of inflammation. B cells may predominate at the center time, but still we don't have biomarkers in order to identify it, and of course there are intrinsic buffering mechanisms of both the CNS and the immune system. Last but not least, no matter whether the immune system attacks and the axons need to resist, at the end it is a matter of their interrelationship and intrinsic properties of the axons to be on the safe side. And just to mention that Professor Lossi also recently admitted in one of his papers that it's not only inflammation, the inflammation association to neurodegeneration does not exclude the possibility that neurodegeneration can exist independently from inflammation. And with some photos from my home city, Thessaloniki, I would like to thank you for your attention.